Welcome, everyone, to the Critical Care Obstetrics podcast. I'm Suzanne McMurtry Baird, the Nursing Director at Clinical Concepts in Obstetrics. And today I'm joined with my partner, Dr. Stephanie Martin, our Medical Director at Clinical Concepts. Today we're going to talk about a clinical issue, but it actually involves hospital administration and the leadership as well. And that is a discussion on clinical care policies that you have at your hospital. So how many of you know your policies in and out, can verbally talk about them, and that your policies really reflect on how you care for your patients?
How many of you even know how to find them?
Yeah. They're
Well,
online, or they're in a black binder behind us at the nurses station. That's what
I don't
hear.
know how many places actually have an actual physical binder of policies anymore. I wonder if that exists. I doubt it. I think most everybody by this time has switched to online. I've not seen any physical ones anymore, but maybe
Haven't.
somewhere,
I know.
But do you know how to get in? Could you find those policies like in a real time crunch if you needed to? How easy is it for you to access your policies?
Yeah, and I'm talking about the exact one. So let's say you had a new nurse who's on the night shift, and no leadership is there, of course, on the night shift. And that new nurse gets an order from a physician or a midwife, and let's say they're going to run MAG on a preeclamptic patient, and she wants to just take that policy, procedure, guideline, and know how to take care of that preeclamptic patient that they're starting MAG on. Would that nurse know how to do that? Would she know how to find the exact information? Because she may pull the preeclampsia, guideline, and it is not, it all it talks about is how to manage severe range blood pressures and nothing about MAG. That may be a different term in your search engine. It may be something completely different in another document that's hidden behind 4 different documents. It may be that the document has a click here, a click there, and click there, and click there. And you may have to go through like 10 different levels just to be able to find how to take care of this patient. And some of this may resonate with some of you, and then others will be like, no, ours is easy. But if it's easy, I want to know what y'all are doing to make it easy, because everybody else needs to know that easy button.
Yeah,
And
it
that's
just
what's,
seems like they just get more and more and more complicated.
yeah.
But I'm wondering if before we even get into it, because you and I have this conversation all the time. We had this conversation prepping for this podcast because the word policy is a trigger word,
Yeah.
especially for Suzanne. For me too, but especially for Suzanne.
Yeah. I
Because
have like an inflammatory response when someone says, oh, it's our policy to run MAG this way. No, it's not.
So let's get specific around the language, because, when a lot of what we're going to be talking about today is risk and risk management, both with patient risk, but also some medical legal risk, because really you are at risk, your facility is at risk, your patient is at risk when your practices and your written instructions, outlines, whatever you want to call them, don't mesh. But if something is written as a policy, Suzanne, if we go into an institution or we review a medical legal case and we see something that is defined as a policy, what does that mean to us?
It means thou shalt. Okay.
Explain.
And
Explain.
it means every time, all the time, 24/7, this is the way we do this here. An example of that might be elective induction prior to 39 weeks gestation is a policy statement. Medical induction could be done prior to 39 weeks, but elective induction is not done prior to 39 weeks gestation. That's a policy statement.
Mm-hmm. Yeah, and there's
But
countless examples of policy statements, things that are, this is the way we do it here, and there really are no exceptions. If there's an exception, it doesn't fit. So if you say, well, there's an exception to an elective induction, the baby was too small. Well, that's not an elective induction. That's a medically indicated induction for this indication.
Right. So, yeah, that is. So everybody just calls everything a policy. And that's the issue. Not everything's a policy. Everything is something in your definition, but it doesn't necessarily mean that the word policy is attached to it. And think of that again, policy is a thou shalt. This is what we do here. And it's usually defined based upon your resources and evidence. So that policy statement about not inducing elective inductions before 39 weeks, there's rationale behind it, right?
Mhm.
There's evidence behind it. And that is pretty much a standard of care everywhere.
Mhm.
Okay.
Mhm.
So that's an example. And then you get into the word clinical guideline, which I like to use guidelines. And that is, to me, how you care for patients at your hospital, and even more based upon your resources and your processes at your hospital. So an example of that may be how you're going to run Pitocin. Okay. It could be a clinical guideline.
I like to think of guideline, like policies are strict. This is the way
Yes.
we do it. If it's an exception, then it belongs under another heading. Okay. I like to think of guidelines as the bumper rails. Okay.
Mhm.
So you use the bowling analogy a lot. Like if you put up the bumpers in bowling, it's going to be hard for you to not hit a pin.
Right.
Okay. It just keeps you in the guardrails so that you're less likely to go out and hit pins in the other lane.
Yeah. Doesn't mean that you can't bowl without the bumpers up when you get really good, and or if you know how to get it down there, and there's an exception to that, and that's where guidelines gives you that ability to critically think.
Mm-hmm.
For this patient, let's just use the analogy of running Pitocin again. For this patient is not responding to the oxytocin like some patients would be. And I've done all of my clinical assessments, palpation and fetal monitoring, and I've palpated, and I am looking out at this patient, this
Mhm.
particular patient,
Mm-hmm.
and she doesn't really match the clinical guideline that we have for Pitocin management.
Mm-hmm.
And we may go to a certain rate, or we may dose it differently for that particular patient. Doesn't
Mhm.
mean that 99% of the time we're not going to do that, but for that patient, that's what that patient needs.
Mm-hmm.
Okay. And that's okay. And that's when physicians or midwives write a note as to why you're going outside of that guideline,
Yeah.
why we're going to be doing something different for this patient. This is the rationale.
So this is this is where the practice of medicine comes in,
Exactly.
because frankly, in medicine, things are much more predictable than we like to believe. We believe kind of that everything is out of our control and there's so much randomness. There's a little bit, but most of it's pretty darn predictable and can be very guideline driven. Look at sepsis. Like the outcomes around sepsis have improved dramatically because of guideline directed therapy. But not every patient is going to be able to fit into that guideline, but the vast majority will.
Right.
The vast majority will. And so you're going to hurt more people by not following the guideline than you will by following the guideline with the exceptions. So let's take an example of a sepsis protocol, right? Where a sepsis guideline, or whatever you want to call it, you've got, this is how we take care of these patients. This is how, when a patient screens positive, this is what we're going to do. But what if you have a patient who is septic, who has a cardiomyopathy pre-existing? You're going to need a specialist involved to determine how to handle their fluid resuscitation without worsening their situation. And it may or may not be what the guideline says needs to happen. So, but you document that and you're getting help with that. But that's not most of your patients. That's a rare patient.
Right. I think of another guideline example is fetal monitoring,
Mm.
which is not a perfect science, which is a tool for screening.
Mm.
And so you have these general
Screening
guidelines.
for what, Suzanne?
fetal oxygenation.
Thank you very much.
At the time of observation. So, you're looking at ways to manage, let's say, a category 2 strip or a way to manage your fetal monitor strip. One size doesn't fit all, for example, on intrauterine interventions for your like fluid bolus, oxygen, or whatever it is that you have for specific fetal monitoring guidelines. One size does not fit all. Every time a patient has a variable does not mean that you need to give an IV fluid bolus to that patient. Number one, fluid bolusing for variable decelerations does nothing except for increased maternal volume status, which increases her preload, which has zero to do with variable decelerations.
Mm-hmm.
But every time somebody has these recurrent variable decelerations, you start seeing 500 cc fluid bolus, which has, again, nothing to do with a variable deceleration. You're not increasing intraamniotic fluid with bolusing mom, And
If
and
only
so
it was that easy.
If only. So your interventions here are this possible interventions for your fetal monitoring pattern, which may include, but are not limited to. I love to see that language in a clinical guideline. These interventions may include, but are not limited to. Why? Because now I'm going to use my critical thinking and to say, these are variable decelerations. Doesn't need an IV fluid bolus, doesn't just for variable deceleration, does not need oxygen, does not need this, but it does need A or B repositioning. That's going to be your main thing for a variable deceleration. So examples in those guidelines, again, guidelines are more flexible and you use critical thinking. And same thing with the term protocol. How would you define a protocol, Stephanie?
Protocol, we're just getting more specific.
Right.
So we're getting more specific to a certain scenario.
Yes.
Like, I'm trying to think of a quick example, but maybe,
Sepsis. Use sepsis.
I was going to say sepsis, maybe your sepsis protocol. So you've got the guideline about this is how we screen for sepsis. This is what sepsis is. These are the general principles. And then the protocol says, this is the dose of the fluid that you bolus. And this is how frequently you're measuring I's and O's and documenting. This is how you're going to do assessment of intravascular volume status. This is how frequently you're going to be measuring vital signs. Very specific and very, very helpful to a bedside nurse, particularly one who is not familiar with that unit or maybe not familiar with sepsis. Like Julie always makes the comment that your documents, your policies, guidelines, protocols, procedures should make it so the least experienced, newest person on your unit will know how to take care of a patient.
Right. Which comes to our last term, and that's procedure. That's just a how to do something. It's almost like a textbook. And one of them that we get a question about all the time is if you have a patient on MAG and PIT, where should the lines plug in? First off, the patient has to have a mainline fluid. That is the one you're going to use as their mainline IV. And then the Pitocin is the second, the one closest to the IV. And then your MAG is a little farther up. Unless you have like a T-set or a set that allows 3 different lines or 2 different lines into the main line. So then that would work. But Pitocin and MAG being high alert medications, you want to make sure that this is standardized. This is the how-to. We're going to do it on our unit at our hospital, which may or may not be the same as a textbook. And I want to kind of expand upon that.
Thank you.
Some hospitals now have deferred all policy guidelines, procedures, protocols to textbooks, period.
If only it was that simple.
If only it was that simple. So,
or like we've been in a facility where their protocol says consult MFM.
Yes.
But they don't have MFMs on staff.
Right. They don't have access to an MFM.
Yeah, they don't have, but yet their own documents say that this needs to happen.
Right.
So
or they
it has
defer
to be
to
customized.
I know, right? At one of them, one hospital that we were in, referred to a textbook set of policy guidelines, and literally the first thing it said was, "Get a stool for the doctor." I'm like, "What? What?" And then it said for the nurse to assist the doctor on doing the cutting the
Episiotomy.
episiotomy. Remember that one?
Yes.
And also with the forceps
Mhm.
delivery.
Uh-huh.
And this is what that hospital was using as their guidance. Can you
Mhm.
imagine a young nurse or a
Mhm.
new nurse coming in on the night shift,
Mhm.
and that's what they read? And I'm like, that is insane.
Or a
That's their
hemorrhage
guidance.
or a hemorrhage protocol that has so much specificity around it with roles, yet the people fulfilling the roles designated in the protocol, or in this case, it was a policy, were not staffed 24/7, like
Yeah.
an anesthesia tech.
Yeah. Yeah.
So it's these level of things that, guys, when we're reviewing cases or we go into a facility, this is not hard to say, okay, well, I see you've got an anesthesia tech here that's running the Belmont or the rapid infuser. Okay, so they're staffed 24/7? No. Well, who runs this on the weekends or at night when they're not there?
We don't.
We don't have anybody that does it.
We've never used it.
Yeah, that doesn't happen here.
Doesn't happen. But that's true. These are all true scenarios.
Yes.
So,
So
yeah.
anyway, we just, understand the language around. We will probably use the word policy incorrectly in this podcast. It's a word that resonates with staff and physicians and everybody when we're describing what's happening in a hospital. But on the documents, this language is very, very important.
Very important. And why is it important? We're going to get into that.
Yeah.
So let's talk a little bit about policy and guidelines sprawl.
Yeah.
We've been in hospitals where they didn't hardly have any, or you couldn't find one. Then we've been in hospitals where they have like 47 policies for the same clinical scenario.
Yeah. It's been an interesting evolution for us because part of what we do in our consulting work is review people's policies, procedures, guidelines, and understanding how to get what we need without getting overwhelmed or underwhelmed with these written policies and guidelines has been an interesting evolution for us. But it's given us real insight as to how, we kind of call it policy sprawl. Like, you don't need a policy for how and when to start an IV. And you don't,
right, exactly.
and you don't need to reference it in every single document where an IV is mentioned.
Right. Or that you need to do I&O with an IV in place. Come on. That's also common sense too.
Yeah. So not everything has to be written.
Exactly. And then I think about the policy sprawl when OB may go off onto their own and write their own in isolation and not include or not, like the key stakeholders. For example, in our patient population, like the ICU or the pharmacy. And so then it's confusing to bedside providers as to what to do when that happens. An example of that would be recent new issue that I've seen a lot of and heard a lot of nurses talk about is, do we need to wear gloves when we are handling the bag of oxytocin? Well, our pharmacist just said that we do, and that we need to do this every single time. And if not, I don't know what's going to happen.
Your fingernails will fall off. Your fingernails will fall. Well, and I also think of, this is another one that we see with like PACU and main OR. Okay, so we might write PACU policies for labor and delivery for C-sections or the OB-OR, but we may be directly conflicting the PACU policies in the main OR. Right. Or we may have different terminology for what an emergency is. Many main ORs already have criteria about what an emergency is, like what cases take priority, right? Yet in OB, we create our own, and that's not necessarily wrong, but it creates an opportunity for confusion. If you have an anesthesiologist from the main OR coming up to cover OR, and we're not using the same language around the urgency of the need to get a case done, that's a potential risk.
Exactly. We've seen that.
Suzanne's lost her voice.
I lost my voice. I talked too much yesterday.
But the other thing we see, and I know that this is going to resonate with a lot of people listening here. And if you're an administrator listening, please take heed. Sometimes we find that these written policies, guidelines, protocols, whatever you want to call it, are like a box checker. We've got it, therefore it's being done.
Yeah.
Okay, I've been told by nursing leadership in facilities where I worked. In one case, I went into an operating room and there were no pumps for the VTE stockings, for the SCDs. And my medical terminology, the VTE stockings. There were no pumps for the SCDs. And so I asked for the SCD pumps. I'm like, we're not starting the case until these are placed. Oh, we'll get it. Okay, I'll wait until you get it. No one could find them anywhere. This was years ago, but it's just an example. No one could find them anywhere. And finally, we found them and we were able to start the case. It took probably half an hour to locate. Turns out there was only one for all the ORs. So I spoke with the nursing director and said, this is a problem we need to address. We have to have these in all the rooms. And the response I got was, this is not a problem because it's written as it exists as a guideline. And I think that's honestly a common disconnect from administrators with what's actually happening on the unit. They believe that if it is written, it is being done. And that's just not the case.
Well, or I think that if something happens in a unit, that they think that they can correct the clinical care by just writing a new
Giving a lecture on it.
Protocol, right? Oh, yeah, or doing a lecture on it.
Do a lecture and write a protocol, and the problem is solved. It's cured.
Right. So it's very. This is not your one size fits all either. So it's not like either you can take again that protocol from somebody else and just say, "Yep, slap it in." That's what we do here. An example of that, CMQCC is great. I mean, they have really driven a lot of the care across the United States, starting with, some of their hemorrhage protocols.
Before you go into that, for those who may not be familiar, CMQCC is the California Maternal Quality Care Collaborative. It's an organization that really drives standardization of care in the state of California and has really led the United States as a result in standardizing care. And many states and many facilities have adopted their approaches and developed their own quality care collaboratives on a state basis. So, because we have a lot of international listeners.
Yeah, all states really have them now.
Yeah.
But the thing that they've done with that standardization is brought their maternal mortality rate down from one of the highest states in the United States to one of the lowest, if not the lowest. So anyway, but they'll take one of their protocols and again just put it into their own system. And again, that you might not have an MFM, or you might not have this or that or this or that that's contained into it, and it will not apply to your hospital. So take it, adapt it.
Yeah.
But then make it your own.
Yeah, I mean, I'll give another example. I've been in a facility where the administration had done great work. They had taken a lot of the CMQCC information on hemorrhage management, particularly stage-based hemorrhage management. Yet a couple of quick interviews with nurses.
Yeah.
Do you do stage-based management of hemorrhage? And the responses were, I don't understand the question. They didn't know what stage-based management meant. So it existed on paper, virtually, but it didn't exist in the unit. It had not been translated to bedside practice. And honestly, that's not unusual.
It's not unusual. We have found it's not unusual at all that staff can't speak to those protocols or guidelines or policies at their hospital when asked. That is really the norm almost when we ask them about it.
Yeah, it is. And then that translates into, then we can translate this even further into All right. Then we get the OB divergence, right? So what about OB? And we're different than many other places in the hospital in many ways. And so the hospital might have a lot of policies on certain things that just don't apply to us, or we're left out,
Yeah.
or we're an afterthought. And so you can have conflict between, OB policies and what's happening hospital wide. I mean, a great example, that's sepsis.
Sepsis, rapid response triggers.
Yeah.
I mean,
Trauma.
vital sign differences. I had to bring up vital signs.
Please
You
do.
know, you got a hypertensive patient down in an adult ED. They may be sent home, but
like
there's
by the
severe
OB
rank.
hypertension.
Yeah, like the OB hypertension, but they may be sent home by the adult medicine people because that's not that high for us, right? Well, it sure is in the OB world when they're 160 over 110, right?
Yeah, 160 over 110 in the non-OB world is not a crisis.
Yeah.
It doesn't create the same sense of urgency as it should in the OB world. So if you've got a pregnant or postpartum patient in the ED with a blood pressure of 160 or 165 over 110, nobody's freaking out.
Yeah. They're like, go see your doctor on Monday.
Yeah.
Keep your appointment.
And I learned this in real life because my mom has had severe hypertension for many, many years, and she's on multiple meds, and she's elderly. And she had blood pressures in the 200s over ridiculousness.
You're about to have a seizure over there.
I'm like, what the heck? And they wanted to control it, but they also don't want to normalize it too quickly. Like there's a whole process in dealing with severe hypertension in an elderly patient who's got chronic severe hypertension, right? Whereas you see those blood pressures in a 26-year-old preeclamptic patient, and this is no bueno.
Yeah. One size doesn't fit all, right?
Right. And so we don't know what we don't know. I'm OB. I don't know what I don't know when it comes to elderly hypertension management. And the ED doesn't know what they don't know when it comes to OB hypertension management.
Right. Another example of that would be pulse oximetry. That's a new deal that we're seeing a lot of issues related to the 92% that is built into these EMRs as their when to become, that's when it turns red, or that's when it puts the exclamation point by it, when it's 92. Well, our patient, if they are at 92, and I'm not talking about living at altitude, 92 at sea level, and they are satting 92. If you're waiting until then your patients are really hypoxic.
Well, not only that, it's the fetus. Like if they're pregnant, your oxygen delivery to the fetus is substantially impacted. That means your patient is much lower on the oxygen dissociation curve, and her PO2 is, much less flexibility for these changes in SATs. And it's a much riskier place to be for a pregnant patient, but that's not necessarily appreciated. But your EHR doesn't know the difference.
No. The same thing could be for labs. Let's start fibrinogen, for instance. There are lab differences, creatinine, and
creatinine's a great one. A creatinine of 1 is always abnormal in a pregnant woman.
Yeah.
Always.
But it's not going to be abnormal on your lab slip.
Nope.
So who wins?
Yeah.
Which protocol wins? It's like, let's say that new nurse looks up in her online catalog of guidelines, and there's like 10 different ways to manage it. Let's say the ICU gives MAG one way and the OB unit gives MAG another way. I mean, ICUs freak out when we give 6 gram bolus of MAG. They're like, you're going to kill them. They're going to be on a ventilator. And you're like, nope, they're going to pee it out. But that's a big dose. So they're going to manage MAG. It's totally different. And there may be like 4 different ways. Maybe the ED has one that does it differently. I don't know. But there could be so many different ways to manage same thing.
Yeah, so you have to know. There has to be call outs for OB. There has to be recognition.
Right.
And each institution is going to have to decide how they're going to handle that. Are they going to have OB specific protocols, or are they going to have OB call outs within the hospital wide protocol?
Right.
I can't say that there's a right or wrong other than to recognize that you can have conflict within your own unit, within your own
Yeah.
facility, I mean.
Yeah.
And then it's which one wins. That's not a conversation you want to get into in a deposition.
Yeah. Same thing with DKA.
Mm. Oh, that's a big one. Blood sugar thresholds, period.
Yes. Period.
Blood sugar thresholds in pregnant patients in the ICU, particularly as delivery is approaching. DKA management, because your ABGs are so different. The use of bicarb in a pregnant patient is a big, big deal. Yeah.
Yeah. Oh, and or when to transition over to sub-Q and things of that nature. And we got, from our experience, I don't know that we've seen an ICU protocol for DKA in a pregnant patient. Have you?
I've never seen one
I've
specific to
never seen one.
pregnancy. No. And, one of the things I do, and I'm deep in right now, is helping MFMs prepare for their board examination. And so when I'm doing these mock exams, because it's an oral exam, you guys may not know this, but the final test, we have to do 4 tests, but the final test to become a board certified maternal fetal medicine physician is a 3-hour oral exam with 6 examiners. It's a nightmare. Okay. And so we do a lot of practice, and I ask them questions like about DKA management and diabetes management in the hospital in general, like in labor and those kind of things. And it's very common for the first response to be, well, I would follow our hospital protocol. Well, I love that they're following protocols, but for the exam, I have to know that you know what's on the protocol and what that management should look like. Okay. And so I will say, well, what is on the protocol? Tell me how you would respond to a blood sugar of whatever. And it's really interesting to see the variation and the lack of understanding of really how to adjust these for pregnant patients. Of course, that's why we're all learning all the time, but this is why guidelines and protocols are really important.
Powerful.
And they have to be modified for pregnant patients.
Yes, that's a classic. And it's a big opportunity for, I would say, most hospitals.
Yeah. And so let me just highlight a couple of reasons why that matters. For those of you listening going, oh my God, what do I need to know about blood sugars in pregnant women that I don't know? A couple things. Number one, euglycemic DKA is a real thing in pregnancy, meaning they can have blood sugars less than 200, less than 180, and
Yes.
still have DKA. So we have to have tighter blood sugar control. And generally speaking, we want our blood sugars in the 70 to 140 range just in living. Okay. And that's going to be timed with meals and all that kind of stuff. But peripartum, around the time a baby is going to be born, you want the blood sugars to be less than 110 to 120 and most people are happier less than 110 because of the risk of neonatal hypoglycemia and NICU admission. Okay. So the neonate, if mom's blood sugars are high around the time of birth, then the neonate is making its own insulin. And then you cut the cord, and the neonate has lots of insulin, and it becomes hypoglycemic. And now we've had a potentially preventable neonatal ICU admission. So there's reasons to be doing all of this. And, so.
So let's continue on our policy discussion. So what is the risk? If you have differing protocols, guidelines, policies within the same hospital, what's the risk?
I mean, I think I think of several risks. I think the one that is probably coming to mind in a lot of minds is the medical legal risk.
Yeah.
But there's potential harm here. Okay. I mean, we'll get into workarounds in a minute, but there's actual harm that can come to the patient, either because of inconsistent care, inappropriate care, delayed care. Lots of different things can happen, right? Then there's individual liability, particularly for the physicians, because most nurses are not really, and midwives, depending on whether they're employed or individual practitioners. But most nurses are employees of the facility. And so their liability is more institutional liability than it is individual liability. But for the individual physician and midwife, unless they are an employee of the hospital, then they have individual liability. And then, of course, the institution. I mean, you guys are hearing about all these awards, these gajillion-dollar awards that are happening from harm. And it having policies, guidelines, and procedures that don't support what you're doing in the unit hurts you.
Yeah.
In these kind of scenarios.
Right. And one of the first things that a plaintiff lawyer will do is ask for the clinical guidelines, the policies, procedures, protocols from the hospital at the time that care was delivered. So when you have these, they're saved over time too, which sometimes hospitals have a hard time producing. For example, I did a case from 1999, not too long ago. I mean, it had gone on for a while, but find your hospital policies and procedures from 1999. Good luck. I think that was when we had floppy disk, or did we even have
We
those
were
at
still
that
on
time?
paper.
Yeah, a lot of paper, the notebook, right? Well, the
No,
notebook's
we were still
gone.
on paper. I was in that
Really?
point, I was in a major institution. It was all paper. Nobody
Wow.
had an EHR there. The only people at that point were Kaiser, really, that had
Well, Vanderbilt
electronic
did.
records.
When I was
Yeah.
there, we had
Um,
electronic records, but we were one
that
of the
that was an
first.
unusual.
It
That was
was
unusual.
unusual. But now
Yeah.
you try to produce those now, and
Mhm.
it's hard. So, and you're supposed to keep them for a certain period of time. So, what did that look like, for that? But the first thing was, what did the policy say
Mhm.
at your hospital? And you have to be able to verbalize what that is, what your hospital policy says. And if it is, well, we didn't follow that here, or I don't know what it was, then it looks like bottom line is you didn't know, right? And there it was in writing. And so they will pull it out and they will ask you individually, they will look at your care and compare it to what is written in the hospital policy or clinical guideline. And that's where, if there's been harm, which usually there is in a legal case, they will compare that and try to say, well, they didn't follow the hospital policy, that they said this is how care is going to be done at our hospital. You didn't follow that, and therefore that's what caused the harm to the
It's just low-hanging
whatever.
fruit,
It is.
from a legal perspective
It
because
is.
it's written. And
Right.
it's real simple to go through and just compare what's charted to what was supposed to have happened according to the policy. So these things are very, very important. There's more wiggle room when it's a guideline or a protocol. And then, we can talk about how and why we deviated from those guidelines or protocols.
And somebody's actually written a note as to why you deviated from that, which
Right.
is, again, okay.
Thought process in
If
real
it's
time.
reasonable. Yeah.
Yeah.
If it's reasonable.
You
Because
know,
standard of care is reasonable care.
yeah. I mean, examples. This procedure, I offered this procedure to the patient. She declined because XYZ. We had a discussion about risk, benefits, and alternatives. The plan is to reassess in 10 minutes, 30 minutes, 1 hour, 2 hours, whatever. It's just a documentation of why we didn't do what it said we should have done.
Yeah.
Okay.
One of the big things that people a lot of times have in their hospital policies, guidelines, again, we're trying to use all inclusive language for that, is how often a nurse should document
Mm.
their assessments. And
Mm.
that comes up time and time again. Well, you didn't document every 5 minutes during the second stage of labor. Well, I was holding a leg, repositioning the patient. What was I supposed to write down every 5 minutes? Like should I type it in with my teeth? I mean, literally, how can a nurse do that, right?
Mm-hmm.
If they're assisting in the birth. I don't know how anybody expects a nurse to do that. So, but if it says that in your policy that you'll assess and document every 5 minutes in the second stage of labor, that's unreasonable.
Mm-hmm.
Unreasonable. But yeah, that's
But
what
that's
you've put in.
if that's what's written, that's what's going to be talked about.
It's what's going to be talked about. Exactly. And same thing, like bringing back the variable decelerations. If it says that you have a category 2 strip, so it's some broad statement like that, not all category 2 strips are managed the same. Again, these interventions may include, but are not limited to. And you go down and use your critical thinking. That is much better terminology than every time you have a category 2 strip, you notify the physician. Hello, 80% plus patients are going to have a category 2 strip. What's reasonable in that care? That I do some interventions possibly, and that if it clears up, do I still have to notify the doc at 2 a.m.? Oh, by the way, we had a category 2 strip. I just wanted to let you know. No, that's not what happens in practice, but it said so in your policy. So, I mean, I do like good clinical guidelines, though. I really do, because I think, again, it provides the bumpers for the bowling, but it really can prevent harm if they're written correctly and things are protocolized and standardized. But it also takes away any bias. So it really assists in equity for equitable care for all patients, that these patients, every patient is going to be taken care of the same way.
Well, and I think what you're saying, to go back a little bit to your point before is, having everything written down is not your enemy. If
No.
what's written down is what's happening and what
Right.
can and should happen
Right.
on the unit. It's different to, the nurse must document every 5 minutes in the second stage is different requirement than writing down that assessment should occur frequently, because assessment is different than documentation.
Right. Well, and I don't even think documentation is what I call the standard of care. The standard of care is something that you do for the patient. And documentation reflects what you did. So you want your documentation to, which is a whole nother podcast, it's a whole day lecture, right? Standard of care is reasonable care that you provide for each patient. And I think protocolized care should reflect the reasonable care for your patient population.
Yeah. And equity, like doing the same thing for everybody every time that has the same diagnosis, need, whatever, that is good care.
Yeah.
There will always be differences.
Right.
Always. And your policies and your guidelines should allow for those differences to take place when necessary. But standardization improves the likelihood that we're going to be providing equitable care.
Yeah. Yeah. Some of the other examples is like that we see are like massive transfusion protocol, who can call, who can activate.
Right.
Differences in a lot of massive transfusion protocols are just about the order of blood that you're going to receive, and a lot of times clinicians cannot verbalize anything about their current massive transfusion protocol that we find. So that is a big one. Oxytocin management, the policy versus the physician or midwife order.
Oh, no one listening has any idea what you're talking about there.
That one comes up a lot.
You're at the bedside. Okay. Yeah. You see what's going on with the tracing, with the contractions, with the fetal monitoring. And the physician or the midwife says, go up on the pit. And the nurse is like, but the policy tells me I can't go up on the pit. What are you going to do?
It's a category 2 strip.
Well, I think it depends on what it is, what you're seeing, and your policy and your guidelines should support that.
Exactly. And that is a huge liability issue in some hospitals. And you're like, why did they write that in their policy that you can't run Pitocin on category 2 strips? What the heck? You're going to never run Pitocin at all then. That's
right. No one's ever going to get PIT if you don't run PIT on category 2 strips.
Yes. I mean, oh my word. That's a face palm. I know.
How about when to transfer a patient?
This is huge for rural facilities. That is so huge. So huge.
And this could be transfer out of your facility, could transfer to a higher level of care within your facility.
Yes.
But are we just going to use bedside judgment, or are we going to standardize the criteria? If this vital sign, if this mental status change, if this amount of bleeding, whatever, then these actions take place.
Yes,
that's an example where it can work in your favor.
Exactly. And I've seen that, again, from level 1 to level 4 centers. I remember a level 4 center, and a patient had been back in the OR for a Procreta. She had lost 8 liters of blood, had not had adequate blood product replacement. They extubated her, brought her out to the regular labor and delivery unit, and said, she'll be great now. The procedure's done. And I said,
And she has a pulse.
She had a pulse. She was breathing
Mm-hmm.
on oxygen. I said, she's going to go to the ICU tonight. And the doc looked at me like, why would you say that? And I said, yeah, she's going to decompensate respiratory wise. She did. But it's that policy. And come to find out, they didn't have any kind of guidelines on how to care for PROCRETA patients. And our statement is, if you do not have an experienced team with that group of patients, then do you do those surgeries at your hospital? The answer to that is what, Stephanie?
There's clear guidance on this, that you have to have an experienced team. You need to have a team, interprofessional, and the resources in your facility to be able to provide this care. But that's an example of something that needs to be written down.
Exactly.
This is not the opinion of the OB or the MFM. We can figure this out and make this happen here. You are not doing your patient a favor. So that's an example of how you need to have written criteria of what you do. And then when a patient starts to deteriorate, that all needs to be, the definition of deterioration needs to be written in a document. It's not a clinical opinion about whether or not she's deteriorating. It's spelled out in vital signs and clinical findings.
Right.
And when you do all of this, you're going to provide better care to your patient. You're going to, in our opinion, reduce staff turnover, because staff like to know what to do and how to do it. Okay. And that includes physicians. When things are done a certain way and it's predictable and reproducible, that helps. And you're going to reduce institutional medical legal risk by having guidelines, policies, procedures, everything written in a way that reflects what's happening on the unit, that's evidence-based, and that is supporting the care that needs to happen, instead of just checking a box that we have a policy. So they've got to be interprofessional. They've got to be current. We review policies all the time. It's not unusual for us to find references that are outdated by 2 updates.
Or using the term like fetal distress or non-reassuring fetal status.
Yes.
Like, what the heck is that?
So, and make sure that your policies are actually reflecting what's happening in your unit. You're minimizing your workarounds. If it's happening a different way in your unit, there's a reason for that. You need to figure out what that is. Something's not working the way it needs to work if it's not reflected that way. Okay. So that needs to happen. So, I want to know your policy and guideline horror stories. I want to know some of the things that you guys are experiencing, the frustrations that you're having in your own places, your own institutions, your own experiences, like what's not jiving.
I would love to hear that. We see our own, but we'd love to know what your practice is experiencing right now. And it may be that you have a solution for it. So we'd love to hear that as well.
Yeah.
How have you battled this?
Well, thanks for everybody for listening. You can find us at clinicalconceptsinob.com and learn more about our education programs, our online critical care OB Academy. We've got lots of great stuff there. You can find us on Patreon. Join our community at Patreon. You can get more of this kind of interactions, some live interactions, and all kinds of fun stuff at Patreon. And find us on all of the social platforms where you find all your social stuff, Facebook, Instagram, LinkedIn, etc. And thanks for joining us and being a supporter.
Thanks, y'all. See ya.